Good evening. Welcome to tonight's 90-minute webinar on moral distress, nursing and bioethics, challenges and solutions. My name is Mary Tresgallo. I am an assistant professor of nursing in anesthesiology at Columbia University Irving Medical Center, clinical faculty at Columbia University School of Nursing, and a clinical ethicist. I am delighted to be participating in tonight's event, an event that is co-sponsored by Columbia University School of Nursing and the Masters in Bioethics program at Columbia University under the leadership of Dr. Robert Klitzman. We invite you to put your name in the chat and to tell us where you are calling from. And later, we also invite you to add your questions to the chat portion of the webinar so that we can present them to one of our panelists during the Q&A portion of tonight's event. Dr. Robert Klitzman will be moderating the Q&A session. We look forward to this being an interactive session and a conversation among experts. That is, all of you that are part of the healthcare team, practicing in multiple settings where you care for patients, families, and each other. The COVID-19 pandemic highlighted the many challenges nurses and other healthcare workers face during their day-to-day clinical practice. The ethical challenges during the COVID pandemic significantly affected frontline nurses. The consequences of moral suffering and moral injury directly impact nurses and other healthcare professionals. These challenges come with opportunities for solutions and change. Tonight, we are excited and pleased to have three outstanding panelists who will lead a robust discussion on moral distress, nursing, and bioethics, its challenges and solutions. The panelists are Dr. Cynda Rushton, who is the Anne and George L. Bunting Professor of Clinical Ethics at the Birmingham Institute of Bioethics School of Nursing and Professor of Nursing and Pediatrics at Johns Hopkins University. We also have with us Renee McLeod-Sordjan, the Vice Dean, Chair and Professor at Hofstra Northwell School of Nursing and Physician Assistant Studies, and Dr. Danisha, the Director of Nursing for Critical Care, Emergency and Advanced Illness in Sharp Health Care in San Diego, California. The panelists are nationally recognized leaders and experts in nursing, clinical practice, bioethics, and the research and ethics of moral distress, suffering, and moral resilience. Dr. Rushton will open the discussion with a focus on the experience of moral suffering, after which Danisha and Renee McLeod-Sordjan will talk about the view from the bedside in being on the front line during the COVID-19 pandemic. Each panelist will share how the pandemic informed their research, their approach to moral injury, and the concept of moral resilience. They will reflect together on the individual and system strategies and solutions that are needed to address the moral suffering of nurses and other healthcare workers. The panelists' presentation and discussion will be approximately 45 minutes with ample time for questions and answers and an interactive discussion at the end of the formal presentations. We look forward to your questions and your reflections. Finally, continuing nursing education credits are available for nurse participants for the webinar today. We have posted the link for continuing nursing education credits in the chat. The link provides you with the information needed to obtain those credits. CNEs are available for those participants that are attending the webinar live today. We thank you for being with us and here this evening and look forward to a rich discussion. Without further ado, I will now turn over the floor to Dr. Cynda Rushton. Thank you.
Thank you, Mary. And it's really a delight to be here with all of you, but to also be with my wonderful colleagues who you'll hear about in just a few minutes. I think as we begin tonight, it feels really important that we pause and to take a moment to take stock of what has happened over these last 20 months, what we have carried individually and collectively, and how we can take a moment to really touch in to our own experience. The numbers of people who have died of COVID in this country now are over 762,000. That's a stunning number. And when you think about the grief that we have experienced individually and collectively, there's no one who has not been touched in some way by this pandemic. And all of us have experienced different types of loss. So I'd like to invite us to just pause for a moment to reflect on the lives that have ended during this pandemic, the people that we've known. Some of them have been our neighbors, some of them have been our family members, some of them have been our colleagues, and many of them have been our patients. Sometimes they have been people we've known for some period of time as our patients, and some we have never known the names. So just in honor of all that you have done in this period, if we could just pause together for a moment. For some of us, pausing has been a luxury. And I think you'll hear in a few moments from my colleagues about the moments that have stayed with so many nurses and other healthcare workers during this pandemic. As you have witnessed, whether it has been upfront and personal in your own practice, or whether you have been someone supporting people at the front lines, there's no question that this pandemic has left incredible moral adversity that has really been intensified by the fact that it's not just the pandemic, the COVID-19 virus, it is the confluence of the social unrest, the social injustices that we have witnessed again and again, particularly around African-American men who have died at the hands of law enforcement, the inequities that we have seen in how people have been affected by this virus, their access to healthcare, and how many have died as a result of our longstanding structural injustice. All of that in the context of a very fractured political climate. And all of those factors have really intensified the moral suffering and the moral adversity that I think everybody has experienced. So thinking about that, what kind of moral adversity have you experienced during this pandemic? Those kinds of situations where it produces some kind of morally objectionable or troublesome or unfortunate result that in the end compromises or threatens our integrity in some way. So just to think about what those examples might be for you as we begin together to explore this whole territory. As we explore this territory, I found myself a number of years ago going back to some very early work that I did back in the 1990s, focusing on the concept of moral suffering and thinking about the varied ways that moral suffering shows up in response to these different types of moral adversity. So in one way, moral suffering is the anguish that we experience in response to some kind of moral harm, wrong, or failure. And what we know is that moral suffering can be ignited by witnessing actions that somehow violate our values, participating in situations that cause moral outcomes that are objectionable to us, or where we personally precipitate those outcomes. So to think about moral suffering as the bigger umbrella, and to think about it in the context of a continuum. So thinking about it in that way, there's an experience of moral adversity. It creates a kind of moral stress where we become aware that there's a threat or a violation to our values. And at that point, we may actually be able to take steps to relieve that moral stress. But often that moral stress is unrelieved, and it may end up causing what is most of us are most familiar with and has been most studied in healthcare is moral distress, which of course has many, many definitions. And we could probably spend hours debating which definition we prefer. I think a simple definition is when we are in a situation where we recognize there's a moral problem and we have responsibility to do something about it, and we're unable to do what we think would be the right thing. What's more corrosive, and I think what we've begun to understand in this pandemic, is a more intense type of moral suffering, moral injury. And moral injury is a term that has really been explored and investigated mostly in the military. It's described as a kind of profound distress that occurs from actions that we may take individually or collectively, or times when we actually should have acted and we didn't. But the bottom line is it violates our sort of moral core. And it often occurs in response to severe transgressions or betrayals. Betrayals that can be personal, they can be collective, or they could be organizational. What we know from the military is that moral injury often occurs in high stakes situations. And if you think about the pandemic, that's exactly what we've been in. And what's also interesting about moral injury, and I was just in a meeting today where people were saying, you know, we thought it was really bad 6 months ago, but things are really worse now. And perhaps because we are now being able to recognize what's actually happened. What's different about moral injury is that it begins to dismantle our own moral identity. It represents a damage to our moral fiber, and often associated with it are feelings of shame, guilt, and for many, it begins to undermine our worthiness as a person. So just to consider for a moment what types of moral suffering you've experienced and how have they shown up for you. With that sort of framing, what I'd like to do is to ask my wonderful colleague, who is also a member of the American Nurses Association Ethics Advisory Board, Dr. Danisha Jenkins, to share a little bit about her experience in the COVID pandemic in the critical care setting.
Certainly. Thank you so much, Cynda. That was really beautiful. So I'll begin by spending about 5 minutes sharing with you a piece written in collaboration with some colleagues on the Ethics Advisory Board and also nurses working here alongside me in our COVID ICU. And this is titled Spinning Plates. So the first time I saw someone balancing spinning plates on sticks was on the San Francisco wharf. He had 6 white plates on poles, all spinning at different rates. The plates wobbled precariously on dowels, threatening to crash to the earth. The man's hands moved too fast to see, deftly accelerating the delicate porcelain, righting itself in an impossible balancing act. His only focus was keeping everything from crashing to the ground. Well, that's us, running from room to room in nursing departments all over this country, hands moving too fast to see. Long before COVID-19, and despite our accumulated trauma, we keep healthcare systems in motion, all the plates spinning at once. Now, more than ever before, we keep it all from crashing to the ground. The painful decisions that nurses have had to make in the course of this pandemic live out of the public's sight and consciousness. Only we know the images that play in our mind in the moments when we are alone. Images we cannot erase. Who gets the last ICU bed? Who will be intubated first? Whose room do you go into when all 3 of your patients are dying? We see headlines about regions declaring crisis standards of care, but rationing of care is not new. At the bedside, it has long occurred due to insufficient staffing and priorities not aligned with safe care, but never to this degree. On a larger, more insidious scale, our health system has rationed care from intentionally neglected communities since its inception. It is only now brought to the public dialogue when it affects those privileged people who have traditionally enjoyed access to all of the care they are now being denied. The destabilization, or arguably the failure of US healthcare, is a story written in the loss of so many lives sacrificed for the survival of the system's profit motives. Stumbling through yet another COVID surge, we face unrelenting trauma that maims our profession in ways yet to be understood, in ways we are afraid to consider and reckon with. So how did we get here? Some of this is our fault. Nurses have long carried the survival of US healthcare on our backs. You could always count on nurses to do whatever it takes to keep the machine running, no matter the cost to our patients or to ourselves. The machine is healthcare, and packaged inside the ribbons and bows of caring and healing is a business that privileges profit over compassion. The commodification of health and of the image and work of nurses has made us a reflection of the system that employs us. And we wonder if we've become cogs in this capitalist machine that is so incongruent with our mission to bring health and healing to our communities. Hospitals have always depended on nurses staying late, working extra shifts, being quiet, and finding a way to make it work. We always have, but we cannot do it anymore. This great resignation we now see is a symptom of both rationing of resources as well as a long-standing capitalizing of the selflessness of nurses. We have long been told that we are not a revenue-generating cost, but what the nurses see clearly now is there is no revenue to be generated without nurses. Healthcare cannot survive without us, and motivations to become and remain a nurse are diminishing. Consequences of compromised standards of care, dangerous patient ratios, and living with the guilt and shame of the care we have not provided when it has been needed most. The trauma and pain experienced by nurses is a case study in the blaring ways the values of our profession do not align with the current essential functions of our job. Day after day, nurses must look in the eyes of the human being they know they may be unable to save for reasons that seem so far beyond our control. The recurrent trauma of COVID-19, wave after wave, manifests in depression, anxiety, substance dependence, and ideation for self-harm. Despite this, we continue to put Herculean efforts to go back to normal, a normal that landed us right where we are today. And it is unclear what it will take for us to admit that this system does not and will not work. If we do not shift from centering the profits of the institution to the needs of our communities and design a system that allows nurses to do their jobs, we will continue trying to function underwater, desperately grasping for air in between crises. So as we consider the patients and nurses harmed by this system, we ask, what happens if we stop holding up a system that hurts people? What happens if we stop to take a breath? What happens if we let the spinning plates fall? So we challenge our profession to end the complicit silence, to speak clearly and push against all forces that contribute to Dr. Jane George's unspeakable, And that is this creation and maintenance of a space in which compassion for oneself or one's patient is severely diminished or nearly impossible. This is where we can start. We see the great potential of our profession, and we aim to rally around the ethics, evolution, and survival of our profession, and to find a place of healing and safety for our patients and for ourselves. This is our voice, and we will begin to write our own story.
Just want to pause and let people sort of take that in, because the truth of what you have shared, I think, is really important for us to look at this situation clear-eyed and to name what is true. And as I was listening to you, I was thinking about the ways in which the moral identity of nurses is threatened and violated when we can't do what we are trained to do. And while we might want to call this burnout, there's something else at play here that is much more corrosive and much more damaging, and that is our sense of who we are. So I want to just thank you for giving some words to that experience. And I wonder if Renee would like to add your experience as an advanced practice nurse during this pandemic.
Thank you, Cynda. Thank you, Danisha. I mean, those are very powerful words for us to follow. I think that identity and who we are, and remembering that we are all registered nurses. So yes, I'm an advanced practice registered nurse, and I've been a nurse and a healthcare professional for over 35 years of my life. And 2020 was to bring much promise. 2020 was to be the year of the nurse, for us to remember the foundational nurse, Florence Nightingale, and how she cared for the sick, how she was present. And what were we asked to do? But to continue that presence in a system, in an era that we thought would never occur. In my role of being a nurse ethicist, I am responsible for 23 hospitals. That was during the time of the first surge in the Long Island region of New York. We saw in 12 days the number of patients increase 300-fold. We saw in our system, in the matter of a month, over 200,000 plus visits. And who was there? The nurse. What did the nurses tell us? That this was warlike. Not like the Crimean War, not like Ebola, not like Hurricane Sandy, not like anything else that we had ever seen. And what are we seeing? We're seeing much more than, as my colleagues have talked about, injury based on shame and guilt. We are seeing post-traumatic stress, the stress that comes from not only our patients that had COVID, but what we were asked was to allocate resources for all patients, not just our patients who had COVID, but our oncology patients, our patients who could not come to see us because they too could not leave their homes. They too were not vaccinated. We were asked to do this and to be present for people that had no family at the bedside. So as we talk later, we talk about all of the strategies that prepare nurses to be resilient. One of the foremost things is effective communication, is being present, is having effective decision-making. But how could we have effective decision-making when what we rely on is community and society to be with us, for families to be with our patients? So as Danisha said, we not only had to choose the choice to watch patients who were dying with COVID, but to not be present for those who were dying without. And to remember that while we were losing our patients, we were losing our brothers our sisters, our mothers, our fathers, our neighbors. So part of this moral injury, part of this moral stress is not being prepared. And that preparation, as Danisha says, not only comes from us as a profession, but for the organizations in which we work to also provide the safety and the catch net to have the equipment and the needs that we needed to be prepared. So rationing, as she said, is not new, but having to ration a mask, having to ration a gown, having to ration the basic needs of others was not what we expected. Nursing is not an individual sport. Nursing is a team sport, and we are used to upholding each other as a team. But we were asked to not only work 4 hours, 6 hours, 12 hours, 24 hours. I will always remember the days between March 30th and April 30th with a phone at my bedside, with 14 hours working as a bedside nurse. Because whatever our role in nursing is, we are at the foundation, present at the bedside for each other and our patients. And my personal injury, my personal stress is not being able to be there for all of our patients, but for each other, not only in my hospital, but in the hospitals that were connected, because we all had to give as much as we could give with very little reserve. And so as we talk about injury, we now need to talk about recognizing, restoring, naming not only the moral injury, but the trauma of what we've endured. Cynda, I don't know how you feel about those words, but I'm curious for your thoughts.
Well, I think you have both given really important language to talk about what people have experienced. And I do think trauma is a word that fits. We do have, we do have some data that Danisha and I both did studies during this pandemic. And the reality is that so many people are experiencing trauma, and many of them are just beginning to realize it. So when you think about that, we have to get the right diagnosis for what it is we are trying to address. And that's part of the diagnosis. I think recognizing the moral wounds that people have experienced, the moral exhaustion of having to deal with so many ethical questions that are just unrelenting throughout this whole process. So, for example, in our own research of healthcare workers during the pandemic, the prevalence of moral injury symptoms that were clinically significant, 32% overall and 38% of nurses, that's almost 4 in 10, had clinically significant symptoms of moral injury. And what we also found is that there was a high correlation between conditions in their work environment. So the people with higher moral injury scores also reported that their organization was not effective in things like not having enough resources, being able to actually have the ability to advocate for our individual patients, feeling as if they were implementing the decisions of others, even when it threatened their own values as a nurse or as a doctor. Some of them were correlated with having to make decisions about foregoing life-sustaining therapies without the usual family members' involvement. And Renee, as you pointed out, one of the areas that I think caused nurses in particular a great deal of moral suffering was when patients were not able to have their loved ones with them. So Danisha, I think you have some data that also sort of points to that reality of moral injury.
Definitely. And what we're seeing, we're still in mid data analysis, but what we're seeing is a strong correlation between morally distressing events and either intention to leave the profession or actually leaving the profession of nursing. And this is a much stronger correlation than what we're seeing with evidence and prevalence of things like depression and anxiety. And to me, this is really important as we plan our interventions, because I'm sure all of us are working in facilities where we have a lot of lavender floating around. We have, some gratitude circles, maybe some sound bowls being implemented. And these are all what I kind of call like the warm blanket when you're in the hospital. These are nice things to have, but if our interventions aren't targeting the moral distress and the trauma, then we're not going to get very far. We're going to continue to have turnover. And more importantly, we're going to continue to see increases in things like substance dependence, suicidality, more depression, more anxiety. And we need to protect our nurses. And like Renee said, the language around this is so important. We use the word burnout so frequently, and it almost feels sometimes as if that word is being weaponized, when what we really need to say, we need the right diagnosis. We need to talk about the trauma that's happening. And this is also so important as we look to policy and resources to support our nursing workforce. Because if we're not giving the right diagnosis, we're not able to extend and offer the support and resources that nurses need. And in many cases, this is professional psychological and psychiatric intervention to help navigate the significant trauma that they've experienced.
Renee, I know you have some thoughts on this as well.
We did themes and attempted to use ourselves as ethicists and ethics consultants to do moral distress rounds, really have people release and report. Well, the themes that came out of that was that nurses felt ill-prepared and their organizations ill-prepared to support them. So we think about the things that organizations did and society did, recognizing us, having nursing hero days, and all of that was wonderful, but it's not sustainable. So I think the other thing that a lot of what we're seeing from even the National Academy of Medicine and even both of your own research is that need to have a sustainable presence, something that sustains, and it's not just for the moment of dealing with the moral injury and the moral distress, but continuing to actually recognize, name it, frame it, and have ongoing support. So, Cynda talked about communities of color and how affected those communities were and how affected that the workforce was. And so we know that the stressors of nurses are increased in these communities. We also have to think about what are the lessons, as we're going to later get to, that are learned that are going to be sustainable. And that's kind of my fear. That yes, we name it, as you said, we put the code lavender, we have ethicists going around having moral distress rounds, but when all of that leaves, what are the long haul syndromes, as you point out, for nurses that leave the profession, but still have the moral memories of what they've been through?
Renee, I think your point, excuse me, about the moral memory is a really, really important one. And it's interesting, when we were doing our research, we had a couple of open-ended questions at the end. And we asked people, what else is it that you want us to know? 41% of respondents answered those two questions. And we did some analysis to try to understand what the themes were. The majority of people who wrote comments had moral injury symptom scores that were clinically significant. So they had something important to say. And what came out of that was themes that had to do with organizational infrastructure, which you both have talked about. We cannot do our jobs well if we don't have the resources we need, and that includes human resources. And that is sort of the code word for staffing. But the reality is we can't do our jobs well if we don't have resources. The other themes in infrastructure had to do with clear communication and having compensation, hazard pay, and other incentives for nurses who perceived they were taking disproportionate risk to provide care. Another infrastructure issue was around consistent enforcement of policies and rules, and how that in and of itself, when you think of being in an environment where issues of inequity are present all the time, it just intensifies the distress. They also identified support from their leaders as an important dimension. And that had to do with, as we've heard so many times in so many different forums, being heard and having their concerns addressed rather than dismissed or avoided. Having leaders who were trustworthy, who actually kept their promises, and who were able to communicate in a way that was clear and understandable, where leaders expressed empathy and true appreciation in the sense of what the contributions that nurses were being made were actually valued. And I think when you think about those issues, what we found in our analysis is that the core issue was broken trust. And then experiencing these large and small betrayals as an erosion of that trust. So I think there are some really important lessons that we could take forward about how do we restore trust in our leaders, in our organizations, our trust in ourselves, and trust in each other, so that we actually can reorient toward why we're here. So I know that Danisha and Renee both have some ideas about some of those structural issues. And I wonder if maybe we could just comment on those and see what else you would add to that.
One of the things, and I think Danisha will also get to this, is how do we go back to create a healthy work environment? And I know one of the issues of Danisha's research is that nurses are leaving. Well, we already have a nursing shortage. And, frankly, nurses aren't at the bedside. I still work in the bedside as an acute care nurse practitioner, among other things. And that idea of seeing the senior nurses stay at the bedside to help and mentor younger nurses is an issue. And so I hope that our organizations and even our national organizations put some thought into mentoring. And part of creating that healthy work environment and part of creating that trust is also knowing that we have a community of nurses. So I don't know what your thoughts are about what you see, Danisha, in your role in terms of building a sense of the bedside nurse and support for all nurses at the bedside.
Yeah, I think a really important start is that nurses as leaders in particular take a hard look at where we potentiate dehumanizing practices in our own organization. And that's towards the nurses that we work with, towards ourselves, and of course to our patients. I think as the team wrote about in that op-ed piece, as long as we have a system that reduces humans into a commodified structure, into amount of money that they're worth based on their insurance plan, we are going to continue butting heads up against this. Now, these are big hairy, challenging problems not one of us can solve. But I think one thing organizationally we can do as leaders is to step into the hurt and look it in the face and call it what it is. And I do see a question here regarding a recent ANA gratitude campaign, and I, of course, cannot and wouldn't speak on behalf of the American Nurses Association, but I can say, as someone who went through this and someone who sees this type of dialogue every day, we hear words like gratitude, self-care, mindfulness, resilience, hero. These hurt, right? And as leaders and in organizations, we need to stop using these tokens as kind of shallow implementations to address the issues we see in front of us. Am I grateful? I am, I'm tremendously grateful to be invited into these sacred spaces of healing and suffering and pain and these, incredibly humanistic, authentic moments that we have with our patients and one another. I am not grateful for any of these institutional, organizational, or societal forces that prohibit me from acting in my full capacity in those spaces. So as leaders, we need to stop saying these things, that are hurting, and we need to talk plainly and clearly and not be afraid to look one another in the eye and acknowledge the pain that has happened. And I think that is a really important place to start.
So Danisha, I think your points are really important in that any concept can be weaponized. And I think what we're seeing is many of these concepts have been used in ways that they're out of integrity with their meaning, and they're being used as a club and a way that people feel that their pain is not being seen and understood. And so I 100% agree with you that we have to start first by creating spaces where we can name what's true and not to sugarcoat it at all. Because if we don't, we are going to continue to see the consequences of this unfold for decades to come. Because we cannot begin the healing process if we don't actually accurately name what is true. The other part of that, I think, Danisha, is too that there's a lot of anger. There's a lot of anger everywhere. And anger is a signal that alerts us that there is something important that we care about that is either being threatened or violated. And so one question, I think, for all of us is, how do we actually harness that energy that it's all anger is, and to be able to use it to propel us toward solutions that actually are sustainable, and to acknowledge everybody's kind of angry right now. Patients are angry, and they're taking that out on nurses. And nurses feel angry about many, many things, understandably. I mean, who wouldn't be? and the public's angry. And so it's not a place where, if anger's the thing that we're fueling, how to use that often moral outrage in a way that actually propels us forward. And I have to say, Danisha, when I was working with you all on this op-ed, the process of transforming that energy into such clear prose was actually a stunning thing to watch, and to see that clarity to come out of that deep place of hurt.
That sounds like it was very cathartic. But I think, Cynda, you said it earlier. We're talking about structural and systemic problems of power, right? So in nursing, we have always had this power imbalance. And I hope where we've moved to is talking about interprofessional teams. And certainly we saw that pain in our young physicians, our young social workers, our young respiratory therapists. So there was that pain. Then there's societal pain. And then you got at these structural inequities of race, equality, inclusion. So there is, like you said, very, very deep pain. And I think it's not an accident that we see and continue to see a reckoning that is happening not only with race, but with power imbalance that is going on in our own profession. And I think that that's something we have to name and address, that this anger is deeply rooted in power and structural imbalances. And yes, as Danisha said, economic imbalances. So I agree with you. Until we name it, until we restory it, until we restart on so many structural and systemic issues, it's very hard to not have this anger and this moral memory of hurt. Danisha, I don't know what you think.
Renee, you had some good examples and experiences of this I would love for you to talk about. But what I've noted through this is nurses have so much anger and have for so long. But one thing we're really talented at is stuffing it to just get through the shift and get through the day, right? There's so many upsetting things that we witness and partake in throughout the course of our day just for the sake of getting the job done, right? And doing the best we can with what we have. And what nurses have lacked for a really long time is a therapeutic, safe, and structured place to articulate their anger. We have not had practice in saying where the pain is coming from, what we're seeing, and what hurts. And, I know we're not to the solutions part yet, and I don't know that this is a solution, but I just want to put out there that we have, where I work, we have been so blessed to have a psychiatrist and psychologist come every other week to our hospital and help to create this space that helps to describe what anger is, where it comes from, and validate the experiences of our healthcare providers and allow these people who have done this tremendous work the space to swear and cry and yell and get out what they need. And what that has cultivated in this group, and we have 30 plus, team members that come every time. What that has cultivated in this group is a really important connection and trust that I think we saw disintegrating throughout the course of the pandemic. We had tremendous teamwork, but the way we were functioning in our anger was isolating. We were isolating from each other, we were isolating from our families, and we were isolating from our communities. As we look at how we can create structural change, nurses need to practice being angry, and we need to practice talking about anger, and we need to learn how to take that anger and fuel it. But until we have this space where we're allowed to be angry, I'm not sure how we're going to be able to sustain getting that work done.
Danisha, it's interesting. 4 million nurses, the majority of whom are women. Women don't do anger well, right? We don't like to admit we're angry. We don't know how to express it. It shows up in all kinds of different ways. And there's another piece of anger that we feel shame about feeling angry, that somehow we're failing, that if we have this emotion, which is expected under these circumstances. So I think you're really onto something important about how do we create those safe spaces where it's trustworthy, where there's confidentiality. And the other thing that you said, Danisha, that I think is so vital is organizations have to make good on their promise to make mental health resources available to people who need them. I have a dear colleague who worked nights as a critical care nurse during this pandemic. At a certain point, she realized that she was experiencing depression, symptoms of PTSD, and she needed to take a break. She asked for a leave of absence for 10 weeks. It took her 9 weeks to be able to access mental health services. She felt completely betrayed by her organization, who said, "We have resources for you," but she wasn't able to access them. So we've got to make good on our promises, to make those available in a way that is trustworthy, that is confidential, that is freely accessible, and that meets the needs of the people who really do need them. And so I think we're definitely in that place of trying to think about solutions. So I wonder, I'm noticing the time, I wonder if we want to pivot toward hearing a few questions, and then we can provide some additional thoughts on solutions. Would that be okay? Bob, would you appreciate that opportunity to take a few questions?
First, I just want to thank everyone. What an amazing panel. I mean, your comments are so powerful and moving and inspiring, and to share as you have the kind of challenges that you've been facing, I think is, I think that in itself, I think will help move dialogue forward among not just nurses, but doctors and others, policymakers, administrators. So from the bottom of my heart, thank you. Really, it's extraordinary, the things you've said. And to people watching us this evening, please, we do see, as mentioned, see this as a very interactive session. So we've had several questions come in, and please feel free to ask questions at any point and continue to do so. Here's a question from Judy Friedson. I worry institutional moral distress support, talking therapy, is just a Band-Aid without major systemic changes. How do we get that message across to upper management in a way that promotes change? So this follows from some of what you've been saying, but I'm wondering if any of the panelists might want to comment on that. How do we get upper management to hear the message and to change?
I guess that I worry that we're not putting the financial resources there, which is something that Cynda alluded to. It deeply disturbs me, and it makes me want to cry that our colleagues have to wait 10 weeks to get the needed care that they need. And yet there's a veiled promise that it's there, but not the financial resources placed there. One of the other things that I'm going to say is that for us as nurses, many of us are the leaders, many of us are the managers, and we really do have to start talking about the budget and not just the number of nurses that we need to replace the flight that we're going to have, but the budgetary resources that we need to care for our own in terms of personal protective equipment, but also in terms of psychological protective equipment. And that are those resources that Danisha is talking about and Cynda's talking about. And I think from an ethics perspective, we're always talking about doing no harm. I think we also have to be the protectors of harm, that we have generations beneath us that have gone through harrowing things in their time. This is the generation of new nurses that have watched 9/11 occur, that have watched Ebola occur, that have had COVID-19 occur. Myself as a young nurse, I remember going through the HIV pandemic and epidemic and not having these resources. And those patients that I lost are still with me to this day. So I think we have to put the finances there. Danisha?
Yes, I think that's so important. And kind of what we mentioned in the op-ed, we are putting so much energy into going back to the way things were. We are trying to get our staffing back to the way things were, our budgets to look like they did in 2019. And in this time of destabilization and disruption, we have a beautiful gift and opportunity to build something different. We can look at this a different way. We can take opportunities to be innovative and dream a little bit more, a little bit outside of the box to say, how do we want the future to look? Because we know that these challenges existed before the pandemic. This pandemic just exemplified everything that was happening and made things a lot more public. So as leaders are advocating for budgets, we need to make sure that we're keeping the nurse in nurse leader and reminding ourselves that our job is to be the voice of the nurses in which we supervise. Our job is to advocate for the patients that our nurses directly care for. So we need to really look at that emphasis and say, do we really want to go back to the way things were? Because I don't think I do.
Danisha, so I love what you both said. And I just want to make 3 comments. One is, I've often said the most important ethical document in an organization is the budget. It reflects what we care about, what we prioritize, and what we are investing in. And so I think we've got to change the narrative about there's not enough. We have proven in this pandemic that there's plenty of resources. The question is do we have the fortitude and the resolve to allocate them differently? The second thing is, denial is not a sustainable strategy any longer. We have got to pull off the blinders. What we were doing is not working. It wasn't working before, and it certainly will not work in the future. And that is what we are seeing right now in healthcare with the great resignation, is what we tried before is not working anymore. And the third thing I want to say is the Barrel Institute, which is an institute that is focused on patient experience, has created a beautiful pledge that is about creating an environment in healthcare that humanizes it for everyone, for the people we're serving and for the people who are delivering care. And I think part of the way forward is we have to commit to rehumanizing healthcare. We've lost so much of our relational integrity with each other, and we have got to restore that sense of shared purpose and to be able to connect ourselves back to why we really are doing this in the first place. And so I think we've got to find the way back to the core of who we really are as a profession, and not to abandon that. You know, it's kind of like, what part do we want to get rid of? I don't want nurses to be the self-sacrificing, you know, we'll always put the finger in the dike. I think we can let that go. But I think we do want to preserve the values of our profession and to make them visible in new and important ways.
So well said. We have a number of other questions coming in. And again, please, everyone who's listening, please feel free to ask others. Here's from David Druin. As an educator of new nurses, how to address the burnout and moral injury in the profession in a way that prepares my students. They need to know, but I don't want to scare them away either.
So I'm so glad you asked that question, because I've been at that one for a while. And I think that part of the answer is we cannot sugarcoat the reality. And that means we shouldn't be scaring people to death, but I think we've got to talk truth. So, for example, we're working on a project now across our state with 8 schools of nursing, and we are developing resources for faculty to engage in these kinds of conversations with pre-licensure students. What students have told us, and we did a crowdsourcing WikiWisdom report during the pandemic, asking students and those who are precepting students what was missing. And what students said is, we want real life experience. We want to work alongside practicing nurses. We want to see what the reality is. And we want to learn skills to manage those realities throughout our nursing career. So for me, we got to start on the first day of nursing school. We don't wait until you graduate to give people the skills to learn how to address ethical questions, to be able to support their own integrity in the midst of these challenges, because they need practice, just like all the rest of us, in addressing those issues in ways that are healthy and wholesome, rather than leaving them to rely on what sometimes becomes detrimental responses.
I can't echo enough your comments, Cynda. And I think the other thing is that they need tools. We're always using simulation to simulate a patient outcome. How about use simulation so that we can delve in reflection and deal with feelings. One of the things that we had to do during this year was to move to a virtual environment. Well, as we moved to those virtual environments, we also had pods of mentorship where there was one faculty with 4 students, because all of the faculty went back to the bedside to take care of these patients. And that was an opportunity to actually role model and role play. So I don't think you sugarcoat. I think it's exactly as Cynda said. We bring them into the journey, but we also give them these tools of reflection, recognition, and voicing so that they don't experience what we experienced 30 years ago.
That's so perfect, Renee. And I think it's important to be very honest about the challenges they will face as nurses, the gap between what we espouse as the values of our profession and the realities of how they're going to be able to enact those in the workforce, but also to really start targeting our education on upstream interventions to these challenges that they will face, and engage our students and our nurses in policy and advocacy. And if that means taking your students to city council to speak about issues with homelessness in the community, because this is the challenge in your emergency department, or bringing them to your county board of supervisors to talk to them about issues in your jails and the disproportionate number of deaths and suicides happening in your jails, because that's so upsetting for the nurses. We need to be teaching them their voice and their power outside of the confines of their hospital walls. Unfortunately, so many nurses feel very beholden to the organization that gives them their paycheck. But we need to be teaching nurses that your license, your voice, your power as the most trusted profession has value throughout the community. And when things seem so difficult and hard and like you have no control, as educators and leaders, we can say, here is where your voice matters.
So this next question follows on that. Danisha, you well anticipated this. This is from Pamela Payne. Do you have suggestions for how we can leverage our power as nurses for change? Work stoppage is so foreign to our nursing values. Is this the only way to get attention of the bean counters? So you mentioned one, going to City Hall, but are there others, or has that happened, or what are ways of facilitating that? Any other thoughts?
Yeah, I don't want to talk too much. I'll stop talking, but there's power in saying no.
Yeah.
Right? We get texts, we get pages. Can you work extra? Can you do this? We can say no, and starting to set those limits and decreasing the expectation that the nurse will always show up no matter the harm to themselves or to their patients. We can start changing that narrative. And I think that's starting to happen, right? Nurses are quitting. Nurses are saying, okay, if this dynamic is this challenging here and this challenging here, I am going to go to the place that pays me more money because that's the version of value that I can get out of this situation. We need to start setting boundaries. We need to not work for free, and we need to make sure that we're asserting the values of our profession.
So, Bob, it's a really interesting question, and I think the whole continuum is exactly starts where Danisha just said. You know, we've got to actually, as people, integrity requires us to know our limits. It is important for us to be able to know when we have reached the point where we are no longer able to adapt, and that's a hard stop. We cannot go beyond that without harm to ourselves, to be good stewards of our own individual resources, and to stand firmly and confidently on that knowledge. There's also lots of other places where we can collectively have a voice. You know, the Lorna Breen Act, which is, just passed in Congress, is an example. But there are so many other places where our voices need to be heard. We are the people who can put a human face on the realities of what is happening in our communities. And nurses, better than anybody else, can talk about the human dimension of the consequences of policy decisions. And that's a place where our voice is both important and vital, but it is also a place where we can serve to fill a gap between what often is a faceless, anonymous, sort of sterile policy to really talk about the consequences of the decisions that are being made at all different levels, including in our healthcare organizations. So having a place where there's shared governance, where there actually is mechanisms in the organization for nurses' voices to be heard and acted upon.
And I just want to say that all of us are nothing without our patients. What gives me voice is my patient's voice. So the question says, is it a work stoppage? And no, we have a social contract to our patients as society. But my colleagues and I are saying that social contract is mutual. Society and our patients have a duty to us as nurses. And sometimes of the voices that are larger than ours come at the bedside saying, do not treat my nurse that way. And I think that that's a powerful collective is our place in the community. And COVID has taught us that more work we did was in the community, getting people vaccinated, getting people tested, getting people to their clinic appointments, doing telehealth. And I think we have to start acknowledging, as Danisha said, that we are bigger than just being inside of an organization. We are society. Society does owe us a debt, and we are grateful to perform the service that we do, to be present for our patients.
Everything you're saying is so moving and I think spot on. It really is wise and wonderful that you're sharing all this and educating us, inspiring us. Here's another question from Pat Allen. Are there any exemplars of institutions that got it right?
That's a difficult one. You know, I will say that I am very proud to be in the institution I was, because there was some forethought to having PPE and proper PPE and what was policy going to look like, and nurses were at the table. But for every small victory, there's still this lingering moral injury that occurred to nurses. And all of the pizza that we were given, or sodas that we were given, or, you know, we care about you and pats on the back, that was wonderful and it was done very well. But the proof in the pudding is going to be, as Danisha and my colleague Cynda have talked about, how are these nurses taken care of next year, 5 years from now, 10 years from now, and 20 years from now? And that remains to be seen.
You know, it's interesting, Bob, I have heard of a couple places, instead of giving people, you know, some small token, have actually given 2 weeks vacation. You know, I mean, when you ask nurses, what do you want? I want a time to recuperate.
Yeah.
And what nurses have said over and over to me is, I am being asked to go back into the very environment that has traumatized me.
Yeah.
I don't have, like in the military, at the end of a tour, a period of recuperation. Nurses who are continuing to work are thrown back into the very circumstances that have caused them so much pain. And when you add on top of that, organizational structures where the pattern of how we staff is to go back to the people who are already employed. And as Danisha said, ask them again and again, when on their days off, to work. That gets experienced as another kind of betrayal, because you're not respecting my need for recuperation and rest. And so I think that we need to really look bigger in terms of what would be meaningful examples of honoring the sacrifice and saying, we are really going to invest in you in a way that you understand as being honoring and respectful. And I do think that one of the gaps is we have got to listen. We've got to listen without an agenda. We've got to listen without dismissing, but be willing to actually hold the hard stuff, because that's the beginning of rebuilding trust.
But Cynda, I'm wondering something, and Danisha, you as well. This felt like a war. And as you said, if we were at war, new troops are sent in. And whether we borrowed troops from San Diego to New York, or whether New Yorkers went to San Diego, you're right, it was the same troops. So I think one of the other things that we have to be able to do is get people into nursing to be the next stronger troops. And I think that that's something that we want our organizations to do, to invest in education, and not just educating the same people. Look, I love the fact that we're all doctorally prepared. Go doctorate. I want every nurse out there to get one. But to invest in our younger people to enter nursing, to pay for that, to pay for workforce, because, people are leaving. How are we bringing people in that are stronger with stronger supports?
I totally agree, Renee. And I think that nursing has had a long history of gatekeeping and presenting barriers to entry, particularly into the hospital setting. And I don't want to conflate this idea that we don't want nurses to have bachelor's degrees, but I want to emphasize what you were saying is we need to look at ADN nurses and LVN nurses, bring them into our organizations and support them in their development as they so desire. But we are not at a place where this type of gatekeeping is going to be beneficial. It wasn't beneficial before. It was very detrimental and created a very homogenized nursing workforce, primarily a white nursing workforce. And what we need to do is make sure that we're creating access to our profession for everyone in our country and supporting the nursing workforce in growing.
So if I could just add one more piece that has to do with the pandemic itself. One of the things we've learned is we have no reserves anywhere. And so we need a National Nurse Corps that is available to be deployed to places where there's great need, instead of relying on, as we have done in this pandemic, other economic drivers to create those mechanisms. And so I think that is a practical thing, looking back on this, that we need to really think about what would that look like. If we had a National Guard that was the National Nurse Corps, where people could be deployed and it could be done in a way that allowed for respite and recuperation as part of that deployment, would that make a difference in our workforce?
Great thoughts, very important. So following that a bit, this is from Ashish Sanan. How do we channel, I think he meant to write, channel the distress and anger into policy reform? And if I can follow up on that, it seems that how also do we educate the public about these issues? I think that a lot of this, as one of you said earlier, the public doesn't see. They see, the news stories, nurses are heroes, that's great, not sort of the suffering, the moral distress that's going on. I mean, how do we change the dialogue politically or in terms of public communication? Or is that possible?
I don't know. I think nurses are the most trusted profession, but we also, as we said, put our fingers in the dike and we keep going. I myself, lost my brother during this pandemic, not to COVID, but he passed away under hospice, and an hour later, I was right back at work. I think that sense of a nurse, that you can rely on them, that we are the caregiver, I say now to everyone out there, is that as nurses, we also need to be cared for. And I think that's the part that the public doesn't get, is that we too have needs that are societal needs. Cynda?
So I love this conversation. We rewrote a piece about this, the need to recalibrate our social contract. And I think a big part of that is recalibrating what a bidirectional contract means and how it is that nurses are able to fulfill their part of that equation, but the public also has to be engaged. And that nurses are not an endless resource. And I think one of the things the public needs to consider is what will happen if there are no more nurses. What will happen in your community, in your health care, and the healthcare delivery? Because the reality is, after a diagnosis is made, what most people need is nursing care. So the reality of the invisible contribution of nursing has to be over. We have to imagine our own narrative about ourselves and how we engage with the public.
Well said. So here's another question. Maya writes, I was just wondering how, as a physician group who has no true power to change hours, offer vacation, etc., but as a colleague, how can we support the nurses in our unit? So this is a doctor saying, how can we support the nurses in our unit? What would you say?
I think it's a journey. I'm going to go back and say something. In 1989 in New York, there was a nursing strike. And the nurses left the unit. And it was the residents who came in and did nursing. Well, when the nurses came back on that unit, there was so much appreciation for who and what we are, from the orders that were written to helping to turn patients, to listening, to opening up the boardroom and saying the nurses need to be a part of the redesign. We are all colleagues to each other. And by no means is our talk saying that we don't acknowledge the suffering of every healthcare worker, but we have to listen to each other and be good interprofessional colleagues. And that means, also voicing the needs of the nurses on your unit, and also saying the nurses need a day off, and also saying, that no, we can't admit an extra patient into this unit because we don't have the nursing staff to care for them. So it's having that empathy, but also that contract between each other to care about each other.
Renee, what it makes me think about is we need our physician colleagues to be good allies, to be able to use the platforms and the opportunities to speak on behalf of, and to carry the message in the places where you have influence, and to be able to do that in the spirit of our healthcare system cannot survive without a healthy workforce. It cannot. And so it's in all of our interests to be thinking strategically and specifically about where can my voice be heard and what is it that needs to be heard, and how can I be a good ally on behalf of the people that I collaborate and work with.
I think sometimes being a good ally means identifying opportunities to pass the mic. I can't remember the percentage, but there's some ridiculous proportion of news pieces in which it is a physician speaking about nursing issues. It's a physician speaking about the nursing crisis, something related to nursing. And these are really excellent opportunities if you as a physician are afforded the opportunity to comment on something relevant or impactful to nursing, to say, I think it's really important that a nurse be speaking on this. And when you're in those meetings and in those boardrooms and things are being brought up that would be tremendously impactful to nursing, to advocate that a nurse be at the decision table and that the voice of the nurse be heard.
All well said. I just want to remind the audience you have a few minutes left. So please, if you have questions, these have been great questions people have been asking, but please feel free to ask other questions. One question I had, so if one is a nurse somewhere and feeling moral distress, what should one do? if I'm a nurse somewhere and I'm stressed out and dealing with the kind of the moral traumas that we're talking about, what should I do? What would you suggest?
I think a really important first step is to find someone to talk to. I think one thing we saw over and over, that as much as we all wanted a vacation, once we did take time, that's when everything really started to unravel. And it's important that you identify risk factors, that your experience is becoming something clinically significant. So if you're having trouble sleeping, if you're having significant nightmares, if your anxiety is out of control, if you're feeling yourself highly agitated, if you're having, thoughts of self-harm, or you just really feel like things are never going to get better, it is critical that you get help and you ask for help. I can't tell you the number of nurses that came to me, and I'm so thankful that they came to me saying that they are not okay, that they are making choices that they've never made before, that they don't know how to cope. Words like, I don't feel like I'm in my body anymore. These are all really important warning signs. And if you're feeling that way, you need to seek someone to support you and help navigate you through this process, because you are going to land in a dangerous place. And we already know that in the nursing profession, substance dependence and therefore suicide attempts are more prevalent in our population than in the general population. So this is something to take so seriously.
And not to self-diagnose ourselves. That is the real key. But just as Danisha said, to get professional help that is beyond yourself.
The only thing I would add to what you both have said is asking for help is an act of integrity. It is knowing ourselves well enough to know when we need help. Asking for help is not failure. It is not weakness. It is actually knowing when we need help and being able to know how we can get resourced in the midst of that. And so part of it is our culture, that asking for help is a sign of weakness. We have got to stop that narrative because there's too much at stake for us not to.
How about from a policy perspective? Oh, here's another question. Sorry. Doodle Mom says, I've heard that nurses don't like to ask for help, but will they turn to another nurse at least, as opposed to chaplains? And I guess another question is the role of chaplains here. I think that is a potential another group of allies, for instance. Are there things chaplains should do and nurses speaking to each other? I'm sure sometimes there are barriers, or what are your thoughts?
I think for nurses turning to each other, one phenomenon we saw is kind of this toxic debrief type of situation. So when you have a group of nurses who have all experienced the same trauma and the same challenges, you're trying your best to support one another, but individually you don't have the bandwidth, right? You're not going to be able to pour into someone else when you are completely depleted. So identifying these things in one another, when you're seeing that your colleagues are unwell or they're coming to you, encouraging them and supporting them in seeking help. And also ending the stigma. I think it's so important that nurses own and celebrate and acknowledge the work that we are individually doing in order to heal, so that we can sustain and keep going and see our profession through to the other side. And I think chaplains are wonderful. EAP programs are wonderful, but these folks also need to identify limits in their ability to care for the extent of injury that they might be seeing. So incorporating the team and encouraging folks to seek professional help when that's necessary.
I just want to also point out that, we are clinical ethicists as well. And during this pandemic, that was a role of ethics. And I do think that organizations have to look at how they have defunded chaplaincy services, social work services, clinical ethicist services, because we are the ones that are in the units, in the hospitals, checking the pulses of nurses and doing some of these collaborations and de-stress and debrief rounds. So this is, I say we asked what organizations got it right. I think that is one of the lessons that we learned, is that organizations that had larger multidisciplinary teams working in this space had nurses that were better satisfied. And we certainly saw that across our hospital systems.
How about Cynda, or was someone
I
else?
was just going to say one thing about Renee's comment, and that is, I think it's an opportunity for us to broaden the lens of what goes into the bucket of ethics. It's not just end-of-life conflicts. And so when you think about creating an ethical practice environment, it is creating an environment of integrity for everyone. And it involves the whole person. It is not just our thinking about these things. It is about how we approach these issues as human beings. And if we can also embrace this more robust notion of ethics, I think it expands the places where our influence can actually be of benefit.
That's great. Well said. One last question. We just have a few minutes left. So I think it was Danisha said, think big, and Cynda, you rightly said we need to recalibrate the social contract. So if you were in Congress, and said to you all, what should we do? How should we sort of rethink the system in some way, or think big? What would you suggest? How could we sort of, appreciate nurses and help them avoid these kinds of problems?
I think one thing is just stop naming one day, 1 week for us, okay? Yes, we need appropriation funding for the resources that support the psychological trauma that is endured by nurses. We need funding for education, and we need expansion, as Danisha said, of new programs that invest and get others interested in nursing from diverse backgrounds, because we are diverse communities and we need more nurses in community.
Great.
Well, I would say we have to blow up the entire healthcare system financing, and we need to really create a system that is not about illness care, but is about healing and health. And we've really, what we're doing isn't working. It hasn't been working, and the drivers are not the right drivers. And so I think that's one thing which would then lead us to new and innovative models for how we are delivering care. We've got to think differently about how we meet people in communities, how we allocate the resources that we do have. And honestly, I think, I spent hours and hours on these elegant plans for how we were going to allocate ventilators. We need to invest the same amount of time into an ethical framework for human resource allocation, because the ventilators and the medicines are no good without people. And that's the part we missed. Go, Danisha. I know you got something to say on this.
Yeah, just absolutely in line with what you're saying. As long as we have a system that dehumanizes people, and one way we do that is through commodifying our patients and commodifying our nurses, we are going to continue to cause harm. So if we're thinking really big, we are going to completely dismantle the system that we have, and we are going to begin to center the communities that we are obligated to serve through our mission, vision, and value statements, and we are going to decenter the profit motives as our driving force.
Well, this has been a fantastic session. I think you've just opened up a whole world of important issues that are vital for all of us to think about, people who are nurses, physicians, patients, family members, policymakers, and everyone else. So I just want to thank all of the panelists, Cynda, Danisha, Renee, Mary. You've all done a wonderful, wonderful job. I want to thank all of you who've listened, who've joined us and asked questions. And we encourage you to stay in touch with us. We'll be sending out a link to the video. If you have friends or colleagues, this will be available on YouTube, and we encourage you to let them know about it as well. And please stay in touch on our website, the Columbia Bioethics Program. We have videos of lots of our other events about COVID, about issues that nurses and doctors have faced in other contexts, not as focused on moral distress as we had here, but might also be of interest. Also about our courses and other resources available. The School of Nursing also at Columbia has lots of resources on their website that might be of interest to you. Most of all, I just want to thank you all. And this has, I think, been a marvelous session. Thank you for sharing all your thoughts. Thank you to my colleagues, the planning committee for this, Mary and Nessa Coyle and Karen Sobeck and Elaine Larson, and my colleagues in bioethics, David Hoffman and Samir Lada, and others. Have a wonderful night. Have a wonderful Thanksgiving, and upwards and onwards. So thank you all very much, and we look forward to being in touch. Take care. Bye-bye.